Hello, and thank you for joining us for today's webinar. A couple housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function on your screen. If you have a question that is not addressed in the presentations, feel welcome to submit through the Q&A feature, and our presenters will try to address as many as possible at the end. Also, today's webinar is being recorded and will be posted on our website. As an attendee of today's session, you will receive an email with the link once it's live. It's now my pleasure to introduce one of our presenters and moderator of the Q&A for today's session. Dr. Judith Mackel is Director of the Cardiac Device Clinic and Director of Cardiovascular Genetics for University Hospital's Harrington Heart and Vascular Institute. She is also the Irving and Virginia Spitz Master Clinician in Cardiology and a professor at Case Western Reserve University School of Medicine. I'll turn it over to Dr. Mackel now, who will introduce her colleagues.
Thank you very much, Tiffany. I'd like to thank both Tiffany Hatcher and Tyler Granger for their help in organizing this webinar. On behalf of the University Hospital's Harrington Heart and Vascular Institute, I'd like to welcome you today to our live webinar. Our topic today is atrial fibrillation, and we'll be discussing an update on some of the treatment options for this condition. I'd like to take this opportunity to introduce my colleagues who are speaking today. Dr. Mauricio Arruda is the director of the Electrophysiology Center at University Hospitals and for the Harrington Heart and Vascular Institute. He is the John R. Antonucci Master Clinician of Cardiovascular Innovation and an Associate Professor at Case Western Reserve University School of Medicine. Dr. Robert Mosteller is the Director of Cardiac Electrophysiology at University Hospital St. John Medical Center. He's an Associate Professor at Case Western Reserve University School of Medicine. And finally, Dr. Antonio Sotolongo, who is our newest faculty member, is providing cardiac electrophysiology services to Geauga and Portage Medical Centers and is an assistant professor at Case Western Reserve University School of Medicine. So I'm going to start off the session today spending some time talking with you about what is atrial fibrillation. So atrial fibrillation is an electrical disorder of the heart's rhythm. It is the most common significant heart rhythm disorder that we treat. It accounts for 15 to 30% of all strokes in the United States, and it results in frequent hospitalizations, hospital ER visits, and physician visits. So in addition to be a rhythm with some serious consequences, it also results in a significant cost burden. So to understand atrial fibrillation, I think we have to really understand what normal rhythm is. So your heart has plumbing and it has wiring just like your house. And the normal heartbeat starts in the top chambers of the heart. So these top chambers, which are called the atria, and the lower chambers are called the ventricle, are where the normal heartbeat originates. At the top of the right atrium, there are specialized cells called the sinus node. These cells communicate with the brain and the body through neural innervation to know how fast of a heartbeat should you have for what you're doing. When you're sleeping, it may fire at 50 or 60 beats a minute. When you're exercising, it increases to 100, 130, whatever the appropriate heart rate is. And when it fires, it travels through the upper chambers, making the atria contract, and then it crosses to the ventricles across a region called the AV node. And then once it travels down the bundles, it results in contraction of the ventricles, which pushes the blood to the lungs, but also out to the body. And that's what you feel is your pulse. Now, when we look at the surface electrocardiogram, this is a recording from the surface of your body of what the heart's electrical conduction is doing. And so the ECG will inscribe a small deflection which corresponds to atrial contraction. So this would be the atria contracting, traveling through the AV node till it gets to the bottom chambers. This tall wave is ventricular depolarization, and then this small wave after is just electrical recovery. When we look at the ECG or the electrocardiogram, we see that before every ventricular beat, there is an organized atrial deflection. And so we would say that this is normal rhythm or normal sinus rhythm because it's originating in the sinus node. In atrial fibrillation, the upper chambers are very rapid and chaotic, and they're not moving in any organized fashion. We think and we know now that many times atrial fibrillation is originating from single foci or regions in the heart that are firing very rapidly. And when they fire rapidly, they drive the rest of the atrium into a chaotic rhythm. And the atria end up fibrillating or quivering. And that's where the name comes from. When the atria were observed in fibrillation, they were actually quivering, and it was called fibrillation. On the surface electrocardiogram, we can see that the atrial activity is very chaotic. It's very disorganized. It doesn't seem to really relate to what the ventricles are doing, but the ventricles are responding in a very irregular and sometimes rapid fashion. We see atrial fibrillation associated commonly with other cardiovascular or heart conditions. By far, hypertension or high blood pressure is the most commonly seen diagnosis with atrial fibrillation. But we also see it in patients who have valvular heart disease, congestive heart failure, coronary artery disease, cardiomyopathies, congenital heart disease, pericardial diseases, and accessory AV connections such as Wolff-Parkinson-White syndrome. There are other medical conditions that seem to predispose patients to atrial fibrillation. These medical conditions that are recognized are chronic obstructive pulmonary disease or emphysema, hyperthyroidism, diabetes, alcoholism, and in patients who have undergone recent cardiothoracic surgery. All of these conditions share something in common. They result in what we call atrial remodeling or changes in the atrial structure. So the normal atria is comprised of healthy heart muscle cells, and you can see them all here in the pink-red color. Once the atria are stretched under high pressure, volume overloaded, inflamed, you end up with scarring. And scarring causes fibrosis in between the muscle cells. That can result in changes not only in the atrial size, but as you can imagine, the conduction of the electrical signal through the atria could be very erratic. And you set up the right substrate for atrial fibrillation. Now, as I mentioned, when the atria are fibrillating and chaotic, they are not contracting normally. This can result in several significant hemodynamic consequences. You won't have the atrial contributing to cardiac output, so every heartbeat will have a little less going out. Because of the irregularity of the rhythm, the filling of the ventricles is different, and so the pulse is weaker and stronger depending on how much time the ventricle had to fill. The rates are sometimes very poorly controlled. That means it can be too slow for your level of activity, but more commonly, too fast for your level of activity. There's also an increased risk of stroke because when the atria aren't squeezing the blood through, blood that isn't being pushed through vigorously has a tendency to clot, and there are a lot of nooks and crannies in the atria that can result in regions where clots can form. Dr. Sotolongo will be talking more about that this morning. Now, this irregularity of symptoms and heart rate and loss of output results in many symptoms. The two most common symptoms that are described with atrial fibrillation are palpitations and dyspnea, which is shortness of breath. Other symptoms are less common, but can also be described. And what's really interesting that about 10 to 12% of people have no symptoms at all with their atrial fibrillation. So this means these are the patients who go for a routine office visit, or they're going for pre-admission testing for a different surgery, and they are found by chance to be in atrial fibrillation. Well, the lack of symptoms doesn't mean that we shouldn't treat the atrial fibrillation. Patients who are having symptoms, however, do experience a decreased quality of life. They have a decreased functional status often because their exercise tolerance is diminished, and they have a decrease in their cardiac performance. Some patients who have poorly controlled heart rates will actually develop a weakening of the heart muscle because it's being driven too fast, inappropriate for the level of activity. So if 10 to 30% of cases are asymptomatic, what we should recognize is that patients who have symptomatic AFib will very frequently have episodes that they don't feel. And so we can't really rely on a patient's report of symptoms to be an accurate reflection of how much atrial fibrillation they're having. The risk of stroke is the same whether the episodes are symptomatic or asymptomatic. And as I said, asymptomatic or AFib that doesn't have symptoms still requires treatment. We classify atrial fibrillation 3 ways. For patients who go in and out of atrial fibrillation and back to normal spontaneously, we call that paroxysmal atrial fibrillation. For patients who go into atrial fibrillation and then we have to do something to restore normal rhythm, which might mean medication, a cardioversion, or ablation, that's called persistent atrial fibrillation. We also have patients who are in permanent atrial fibrillation. So this means that despite our best attempts, we cannot restore sinus rhythm, or patients who we've determined we are not going to try to restore sinus rhythm. They are classed as permanent atrial fibrillation. Now, people often ask what triggers atrial fibrillation, and Dr. Mosteller will be speaking today on lifestyle modifications to help decrease atrial fibrillation. But in large series of patients who have paroxysmal atrial fibrillation, trying to identify a trigger has been very difficult. In 2 large studies, we can say that emotional stress was associated with the onset of atrial fibrillation more frequently than any of the other triggers. One of the things we can't change is age, and we do note that as you age, the prevalence of atrial fibrillation does increase. Men are at a higher risk of AFib than women, but when you get over 80, there actually are more women than men alive, and so we actually see more women with atrial fibrillation, but the prevalence is actually a little higher in men. And we do note that due to our aging population, we expect over the next 30 years that we'll be seeing even more atrial fibrillation than we're seeing now. As I said, there are many treatment options to address atrial fibrillation, to control the rate, to maintain sinus rhythm, to prevent stroke. We'll be covering several of these in more detail this morning. Dr. Arruda will be discussing catheter ablation to maintain sinus rhythm for patients with atrial fibrillation. Dr. Mosteller, as I mentioned, will be talking about lifestyle modifications. Dr. Antonio Sotolongo will be talking about how we reduce the risk of stroke from atrial fibrillation. And so I would like to introduce Dr. Mosteller for lifestyle modification. Thank you.
Very good to be with you all and to be able to talk with you about atrial fibrillation and lifestyle modification. As Dr. Mackel mentioned, there are many causes of atrial fibrillation, and here's just a little short shopping list of things. And as you can see, many of these you can't do a whole lot about, especially the advancing age. I may identify as a 25-year-old basketball player, but I can't run full court anymore like in the old days. So you can't modify some of these. However, alcohol consumption can be modified, sleep apnea can be treated, thyroid issues can be treated. And so we do our best to treat the cause behind the atrial fibrillation before we then focus on the specifics of the atrial fibrillation management. This diagram here is going to be my main diagram. It's called Pillars of Atrial Fibrillation Management. As Dr. Mackel pointed out in her talk, there are three kind of, if you saw me as a patient, I would sit down and talk with you about the big three goals that we have for managing your atrial fibrillation. The first goal has been rate control, to keep your heart from going too fast, because that can give you a different problem called congestive heart failure. So we try to control that heart rate. We also try to keep you in normal rhythm if possible, and have a variety of medications to do that. And then the third of the big three goals is preventing blood clots that could lead to strokes. And we generally do that with drugs called anticoagulants. In this recent symposium from the American Heart Association, they have added a fourth pillar, and that is lifestyle and risk factor modification. So that's what I'd like to spend a few minutes on. How can lifestyle changes affect your atrial fibrillation? And I'd like to look in the next few minutes at just four things that may have an impact on the amount of atrial fibrillation you have. Before we dive into that, though, I want to bring up this concept that we call atrial fibrillation burden. Atrial fibrillation burden basically asks the question, what percentage of the time are you in atrial fibrillation? And as Dr. Mackel mentioned, some people are acutely aware of every single episode. Other people are blissfully ignorant and don't know when they're going in and out. So we see it all across the spectrum. But how do we figure out what percentage of the time you are in atrial fibrillation? Well, that can be a tough call if you don't have symptoms. So how do we make that diagnosis? Well, we have a variety of external monitors that you can wear. Many in the audience, I'm sure, have worn a Holter monitor for 24 hours, maybe up to 72 hours, to record every heartbeat and see if you're in sinus rhythm, if you're in fibrillation, what percentage of the time in each. We have longer term monitors, such as the picture right here, a monitor that kind of pastes to the skin and can be in place for up to 2 weeks to identify the percentage of time you're in fibrillation. And now some of the new smartwatches, like the Apple Watch 5, has the ability to give us this information. We also have internal monitors. In about 2 hours, I'll be implanting one of these little guys. It's a little gizmo that you can see here in the picture on the right. Just a tiny little unit that goes underneath the skin, and it can stay in place for 3 to 4 years and check your rhythm and give us an exact percentage of the time you're in atrial fibrillation. Furthermore, if you have a permanent pacemaker or a defibrillator, those generally will keep tabs of what percentage of the time you're in atrial fibrillation and can thereby give us our atrial fibrillation burden. So what kind of things might decrease your atrial fibrillation burden? Well, there have been several trials in the last few years looking at these things. One of the trials was from about 3 or 4 years ago, dealing with physical activity. And it took people who had those little monitors and had 51 patients sign up for a research trial. They were known to have atrial fibrillation, and they all had these little loop monitors. And this is kind of how we get answers to these questions. When we sign these people up, they don't get a choice of which group they get into, nor does the physician get a choice. You basically flip a coin, and in this instance, say you flip a coin, and all the people that came up with heads, they got assigned in this trial to 12 weeks of rather intensive aerobic training to try to really get into shape. The other people who you flipped on tails were assigned to no aerobic training. And so what did they do? Well, they looked at the 4 weeks before this 12-week training period, and then the 4 weeks afterwards on the little monitor that was implanted, and they compared before and after. What they found is that in the people that got involved with regular exercise, their atrial fibrillation burden in this trial went from 8.1% down to 4.8%, showing some definite benefit in decreasing the atrial fibrillation burden from exercise. Meanwhile, the people in the non-exercise group, I guess, were busy watching Netflix, and they must have been watching violent shows because their atrial fibrillation burden went up from 10 to about 14%. But this trial and several others have shown some benefit of physical activity and aerobic training in decreasing the amount of atrial fibrillation burden a person has. How about weight reduction? It's very well known that atrial fibrillation is more common the more obese a person is. Typically with a BMI or body mass index of greater than 30, we start getting concerned, and there's no question they track together. Dr. Arruda is going to speak with us later about catheter ablation, and we know that catheter ablation results are much, much better in people who are not obese. They don't recur nearly as much. So here was a trial where 150 patients who met the criteria for obesity signed up for a research trial. And again, they don't get to choose. The doctors don't get to choose. They were just assigned. And 75 of them, half of the patients, were assigned to an intensive weight loss program, and the other 75 just try to do the best you can, lose weight on your own. And what did they find? Well, the people with the intensive weight loss program lost an average of 14 kilograms, which is on the order of 30 pounds, and they definitely had a much lower burden of atrial fibrillation, at least symptomatic fibrillation. The people that tried to lose weight on their own dropped 3.6 kilograms on average. That's less than 10 pounds, and they had a much higher burden. So another thing we know is that losing weight, especially if your BMI is over 30, can certainly lead to a decrease in your atrial fibrillation burden. Another big one that we see is sleep apnea. I just saw a gentleman in the office yesterday who is actually not very obese, about 6 foot tall, 180 pounds, but he's had atrial fibrillation and no one knows why. And we sent him for a sleep study, and he's got rather severe sleep apnea. I was tipped off that he might have that because his wife mentioned that he's a snorer. Most people with sleep apnea are snorers. And there have been quite a number of studies to show that if you have sleep apnea and get it treated, typically with a CPAP mask or a BiPAP mask like this, you'll have a lower burden of atrial fibrillation. Whereas if you do not use a CPAP mask and continue to have problems with sleep apnea, which is actually stopping breathing, that puts a strain on your heart and makes you more prone to atrial fibrillation. So this was what was called a meta-analysis, where they looked at 8 different trials and clearly showed that CPAP users have a much lower burden of atrial fibrillation than people who have sleep apnea and do not get that properly treated. How about alcohol? Well, we all know that alcohol can trigger atrial fibrillation. In fact, we see it frequently on January 2nd. It's called holiday heart syndrome. Patients drink a little too much over the holidays and come in with atrial fibrillation. So does reducing alcohol have a benefit? Well, this I think is the funniest of the trials I reviewed. This was done in Australia and New Zealand, where they apparently really know how to put them away down there, I guess, because they took 140 patients who were known drinkers, heavy drinkers, that had atrial fibrillation. And they signed up for a research trial, and they got put in one of 2 groups. 70 patients were assigned to complete alcohol abstinence, which is going to be a tough thing to do, but they tried their best, whereas the other 70 were just trying to scale back on their own. And what did they find? Well, the abstinence group, they didn't quite quit completely, but they went from a total of 16.8 drinks a day, which I can't even comprehend of, down to 2.1 drinks a day, and had a much lower atrial fibrillation burden than people who just tried to cut back on their own, did not join a program. Their consumption remained high, 16 drinks a day to 13 drinks a day, and they had a much higher burden of atrial fibrillation compared to the group that largely gave up alcohol. So that's one thing we try to stress with our patients, and there is a genetic susceptibility here too. Sometimes even 1 or 2 beers a day can make you much more prone to fibrillation based on your genetics. So the conclusion of this is that alcohol reduction or alcohol abstinence will decrease your atrial fibrillation burden. So putting it all together, regular physical exercise, weight reduction, treatment of sleep apnea, and a reduction, elimination of alcohol intake, all of these things can significantly decrease your atrial fibrillation burden and allow you to feel better, to stay in sinus rhythm for a longer time frame, and have a better quality of life. Now, returning to our 4 pillars of atrial fibrillation, I just want to touch on a few of the others. For the rate control, we frequently use beta blockers, drugs like metoprolol. We also use diltiazem or verapamil. Those are calcium channel blockers, digoxin. So these are just kind of damage control drugs. They don't really prevent the spells to speak of, but they keep you from going too fast when you're in a spell. One of the other pillars, of course, is preventing blood clots and strokes. And Dr. Sotolongo is going to talk to us about ways that we might be able to do this without using these drugs that many of you know: Coumadin, Pradaxa, Xarelto, Eliquis. These are good drugs to prevent blood clots, but can lead to significant bleeding, and it can lead to serious problems. So, but the risk of stroke is real in patients with atrial fibrillation. And I don't know about you, but my soul is well prepared for death, but it's not well prepared for a disabling stroke. And so that's really a big fear that we have. And I hate to see patients suffer strokes that disable them. So we're very, very aggressive about trying to prevent strokes, generally with these drugs, but there may be other ways, as Dr. Sotolongo is going to share with us. And then finally, trying to keep patients in normal rhythm is a challenge. We use a variety of what we call antiarrhythmic drugs. I listed some here: flecainide, propafenone, also known as Rhythmol, Sotalol, a drug called Ticasin, or known as dofetilide, amiodarone. These are some of the drugs we use to try to maintain normal rhythm, but it can be a difficult thing to do. And people sometimes have side effects from the medications, or the medications are not effective. So the question remains, is there another way we can keep you in normal rhythm without these medications? And Dr. Arruda is going to share some insights with us in that regard. So with that, I will turn things over to Dr. Sotolongo to talk with us about prevention of strokes.
Thanks, Bob. Hello, everyone. Let me share my screen. Hold on. There we go. So we've been talking a little bit about lifestyle modification, what atrial fibrillation is. But if you ask me, like Bob was saying, what is the most dangerous thing atrial fibrillation can do is give you a stroke. And there is a risk between atrial fibrillation and stroke. So we'll be discussing this a little bit in the next couple of slides. What is the risk? What is the risk depending on each individual patients, as well as what strategies can we do to minimize that risk as much as possible. So in terms of general statistics, having atrial fibrillation will increase your risk for having a stroke at least 5-fold compared to patients without atrial fibrillation. And about all the strokes out there, at least 15% of all strokes are attributable to atrial fibrillation, about 75,000 a year. Atrial fibrillation strokes tend to be more severe. They are twice as likely patients to become bedridden after an atrial fibrillation stroke, as well as they're associated with a higher mortality. And this stroke risk, like Dr. Mackel was saying, this stroke risk persists regardless if you have symptoms or not. So if you're having palpitations, if you're having fatigue, or if you feel completely fine and you don't feel anything at all, your stroke risk is there as well. That's also the case whether you're paroxysmal, which is if you're going in and out of atrial fibrillation, or as well as you're persistent. We treat all these patients the same. There's a stroke risk for all these types of atrial fibrillation regardless. But not everybody has the same stroke risk as everybody else. And we've noticed from several studies that your stroke risk is dependent not just on your age, but also on your individual medical conditions. So what you have here, this is a chart that we use. We actually do this for every patient that comes into the office. This is what we call the CHADS-VASc score. And what it does is it adds up your age as well as individual risk factors such as congestive heart failure, hypertension, diabetes, vascular disease, as well as history of stroke or embolism. And what we do is each one of these risk factors adds a point. And once these points, you add them all up and you put them on the chart, you can see that depending on how high the score is your adjusted stroke risk a year. And as you can see, the risk varies wildly depending on your score. So you can have, for example, if you have a low CHADS-VASc score of 0 or 1, your stroke risk could be as low as less than 1%. But if you have a very high CHADS-VASc score, you can have an adjusted stroke risk of at least over 15% per year. So each patient is different. Each patient's risks is different. And I think when we talk about what to do to prevent these risks, we should really individualize to each patient. So what can we do to prevent strokes as much as possible in patients with atrial fibrillation? So I think the cornerstone is really anticoagulation, which is what we normally call blood thinners. As a general rule, anticoagulation, we recommend them in most patients with a CHADS-VASc score of 2 and above. And the reasoning for that is at that point, when your CHADS-VASc is 2 and above, the risk of stroke is significantly higher than the adverse effects from an anticoagulant. How much does it decrease the risk? So that's been answered in several old studies where they took warfarin, which is one of the oldest drugs for anticoagulations. We still use it today, and we'll talk a little bit about it later. And they compared it to placebo. So these are 4 trials. The blue bars are patients in the placebo group, and the red bars are patients in the warfarin group. As you can see across all 4 trials, there's a significantly lower risk of stroke in the warfarin group. So how much does it reduce the stroke risk? So it's about 2/3 less or a little bit over that when compared to no therapy. So it'll significantly reduce the stroke risk. What medications can we give? So these are the 5 anticoagulants that we have available. The most common anticoagulant and the oldest one, the most affordable one is warfarin. I'm sure a lot of you guys have heard about it. This medication is also one of the only ones that we can use in some patients, especially patients with mechanical valves, as well as some valvular conditions. But this medication does come with some issues. So it does interact with several other medications that patients take, as well as interact with several foods that patients can take as well. Additionally, it's kind of a pain for the patient and the provider when you have to deal with managing Coumadin, and that's because managing Coumadin requires periodic monitoring of how anticoagulated your body is. Each patient's dose is different, and we risk if we don't monitor it accordingly and your dose is too low, you might be taking too low of a dose and you're not protected well enough. Or alternatively, if you're taking too high of a dose, then you could be at increased risk for bleeding unnecessarily. The other 4 medications, so the brand names are Eliquis, Xarelto, Pradaxa, Cevisa. These are the generic names on the left. So these medications, we call them the novel oral anticoagulants. They're not that novel anymore. I think Pradaxa is over 10 years now. But these medications they're not for everybody. There are some caveats for each one regarding which ones we get to use. So we do have to individualize to the patients, but it does have the advantage over Coumadin that we do not have to necessarily check every patient to see if they're anticoagulated. So these drugs have predictable pharmacokinetics. So the dose that we give you is really based on your kidney function. And usually with that dose is good enough and we don't need to check anything else. So it's definitely an advantage. That being said, there are some problems right now with it, specifically affordability. So depending on your healthcare provider, sometimes these medications can become expensive and sometimes prohibitively expensive as well. Another point I wanted to make when we're talking about anticoagulation. So I know when we talk about anticoagulants, these are really the 5 medications that we're talking about. Aspirin, clopidogrel, Plavix, Brilinta, all these other medications that you guys might be taking for other cardiac conditions, they are not suitable alternatives for stroke prevention. So if you're at a higher risk for stroke with atrial fibrillation, in other words, if your CHADS-VASc is relatively high, and aspirin or Plavix is not a suitable alternative, you should probably be on one of these 5 medications. But again, each patient is different, so we have to talk to our doctors and individualize treatment. Now, as we all know, anticoagulation does not come without side effects. And there are some patients that there are an increased risk of bleeding compared to the general population, and they cannot tolerate anticoagulation and long-term use of anticoagulants. So what can we do about these patients? So this on the left of the screen, so this is a model, a 3D reconstruction of the left atrium, so the left upper chamber of the heart. So just as a review, the left chambers of the heart, these are the ones that pump blood out into the rest of the body, okay? So the left upper chamber of the heart, like Dr. Mackel was saying, when they're in AFib, the heart is quivering instead of actually beating. So you can see how blood can sludge in this area, and it can create clots in some areas of the heart. Over 90% of clots in the left atrium are usually in the left atrial appendage, which is this little finger-like structure in the upper here on the screen. So it stands to reason if we could eliminate the left atrial appendage or somehow seal it off, then we could potentially reduce the stroke risk in patients without the need of anticoagulation. Here on the right, you have an echocardiogram that's actually focused on the left atrial appendage. So this is a sonogram of the heart that's focused, and you can see a huge clot in this appendage in a patient with atrial fibrillation. So surgeons have actually been doing this for quite some time. When patients go into cardiac surgery, they have a history of atrial fibrillation, depending on the surgery. A lot of them clip off or ligate the left atrial appendage, and this is served well in some patients. And again, this is something that we do use in patients that are going into cardiac surgery. But if you're not going into cardiac surgery, it's a big procedure just for this. So what else do we have? What we've been developing over the course of several years is ways to seal off this appendage in a way that's minimally invasive. So what we have here, this is the Watchman device. This is the most commonly implanted left atrial appendage occluder. We do these routinely at university hospitals. We've done hundreds in the past several years. It's kind of a little umbrella. It's a nitinol frame with a membrane on it. The way this gets implanted into the left atrial appendage is we go in through a vein in our leg. We go up to the right upper chamber of the heart, which connects to that vein. From there, we cross to the left atrium or the left upper chamber where the appendage is, and we deploy it there and release it. We deploy it using ultrasound. Over here, you can see the Watchman on the left atrial appendage, as well as we use X-ray guidance throughout the whole case. The whole procedure takes about 45 minutes to do. Patients come in, they usually go home the next day. In terms of anticoagulation and when to stop anticoagulation once there's a Watchman. So these are animal models as well as human pathology data. You can see after 45 days, so the tissue around the tissue in the heart starts growing around this mesh, and you can see how it seals up. So this is at 30 days. At 45 days, you can see there's almost a complete seal, and it completely seals off the left atrial appendage from the rest of the heart. So after 45 days, we actually do a sonogram of the heart, make sure the seal is good, and if the seal is good, then at that point we stop the anticoagulation. So which patients would this be a good alternative? So they would have to be patients with a non-valvular atrial fibrillation. They would have to have a high risk for stroke, so a CHA2DS2-VASc of over 2. And they would have to, at least for the time being, there are some studies on this, but at least for the time being, they would have to be tolerant to some form of short-term anticoagulation. And then they would have to have an appropriate rationale to not be able to take anticoagulation, either because of prior history of bleeding, increase in the fall risk, or issues with their lifestyle or with their medications. In terms of effectiveness, so there's been several trials on this, and it's not inferior to warfarin in the prevention of strokes. In terms of success rate acutely for the procedure, the success rate is over 95%. And in terms of complications, we've actually gotten better over time. So if you compare the complications rates in the trial before the approval of the device compared to the post-approval experience, the complication rates are extremely low and usually average at about a little bit less than 1.5% per patient. So in summary, atrial fibrillation is associated with significantly increased risk for strokes. The risk is very different from patient to patient, and it will be associated with increases in age as well as the presence of other medical conditions. Anticoagulation remains the cornerstone of reducing the risk for stroke, and the choice of anticoagulant really depends on a patient-to-patient basis. and depends on many patient factors. In patients who cannot take anticoagulation in the long term, I think the left atrial appendage occlusion is a very viable alternative. So that's about it. We'll move it over to Dr. Aruda, who'll be talking a little bit more about rhythm control with catheter ablation.
You can see I'm sharing my screen here. Where is my first slide? 20. Hi, thanks, Antonia. Good morning. Thanks for joining us. I'll be talking to you about catheter ablation, which is a potentially curative approach for atrial fibrillation. As Dr. Meckel showed you before in the electrocardiogram, the heart rates can be very irregular as very slow at this segment here and progressively faster at this point. And if we're to look, getting electrical signals from inside of the heart itself, you notice that the upper chambers of the heart are in the complete...
Mauricio, we're not seeing your slides. So I don't think your share screen is up.
Is it better? Is it there?
Yes, there you go. Thank you.
Okay, I'm sorry. There. Okay, as I was saying, this is the electrocardiogram of a patient with atrial fibrillation, and you see the irregular heart rate is slow at this point and progressively faster. And as we go into getting recordings from inside of the heart, we notice that in the left atrium and right atrium, the chambers are in a complete electrical storm as seen here. As shown before, the upper chamber is quivering in producing often irregular heartbeats, making the heart to function as in a desynchrony mode. There's no enough synchrony to work as a significant effective pump. As shown here in normal rhythm, on the other hand, as you see the electrical activity starts in the upper chamber, the right atrium, it spreads down to the pumping chambers in the bottom, and the heart works very well, very efficient as a pump. The atrial fibrillation, as you've seen, is the most common heart rhythm abnormality, and unfortunately is a progressive process, as Dr. Meckel showed you some slide, with scarring in the left atrium or scarring produced atrial fibrillation, on the other hand, in some patients. In a large survey of patients with atrial fibrillation, note that once AFib was first diagnosed, the first episode of atrial fibrillation, until it becomes permanent, where there is no forms of treatments to restore normal rhythm, may take only 3 to 4 years for that progression. And in 20% of patients, or 1 out of 5, the atrial fibrillation can progress to become persistent within 1 year. So here's the anatomy of a human heart. Once again, the pumping chambers, the right ventricle and left ventricle, and the right atrium up in this corner here. The left atrium is located in the back of the heart, shown into this view. Note the left atrium has 4 blood vessels, large blood vessels called the pulmonary veins. They come from the lungs to bring oxygenated blood into the heart so it can be pumped throughout the body. What we've learned over the last 2 decades is that when atrial fibrillation started, as shown here, so you have 2 beats of normal rhythm, there is an electrical firing, the so-called trigger for atrial fibrillation. The patient goes into atrial fibrillation. In a majority of patients with atrial fibrillation, this trigger is contained in one of the 4 pulmonary veins. Here is the dissect human heart, if you will. The right atrium and the left atrium. In the right atrium, this dotted area contains our natural pacemaker that we're born with, the sinus node. And the left atrium, see the heart muscle extension into the pulmonary veins. And it stretch, and for other mechanism, there is potential electrical firing in one of these veins that starts atrial fibrillation. So catheter ablation may eliminate or decrease the episodes of atrial fibrillation. And with a less burden, as Dr. Mastella said, there is a significant chance of increased quality of life, decreased hospitalizations for atrial fibrillation, and even decreased mortality in our population with atrial fibrillation. So how we perform the procedure. So remember, the atrial fibrillation ablation is a hard cath-based procedure. There's no surgery, there's no cuts or stitches. Our typical patient would arrive the morning of the procedure into our laboratories, meet the staff, meet the physicians, and procedure gets started. The first step is to go under general anesthesia for most cases. And once patient is ready, we will start by placing our catheters into the heart, and we access the heart from the right femoral vein. It's a large vessel in the right groin that we visualize under ultrasound, stick the vessel only with a needle and put our tools up into the heart. Once we arrive in the heart, we land into the right atrium. As I said, we need to ablate the left atrium. So we cross at the center between the upper chambers where babies have a hole. In most adults, this area is very thin. That's where we cross. As seen here, once in the left atrium now, we identify the anatomy, have it in a three-dimensional reconstruction of the left atrium in a computerized system, and we start delivering ablation. The goal is to go around each of the 4 pulmonary veins to make them electrically isolated, electrically silent. Therefore, if there is a trigger for atrial fibrillation inside of one of these veins, it will no longer be able to come out and induce atrial fibrillation. So catheter ablation can be performed by delivering radio waves through the catheter into the heart muscle, the so-called radio frequency energy, but also by freezing the tissue with cryoablation. In this example, there is muscle, and delivery of radio waves here produce, as you see here, by heating the tissue, a significant lesion that we call, and eventually will take 2 to 3 months for a completely healing of this process. So the FDA first approved a catheter to be performed, to be used for catheter ablations a few years ago. Noted that working with the catheter company, the FDA randomized patients into receiving the catheter ablation as first-line treatment for this patient in 106 out of 167 patients. The remaining 61 patients went to drug treatment, medications for AFib, or the so-called antiarrhythmic drugs. If you see here the freedom of atrial fibrillation over time, note that patients that underwent catheter ablation were significant more successful as far as eliminating the AFib than in comparison to antiarrhythmic drugs down in the bottom here. And based on that data, the striking difference as first-line therapy, the FDA approved the catheter and the procedure for atrial fibrillation is well recognized. Here's in one of our patients. Note the right atrium again here in the CT scan of this particular patient, and the left atrium in the back, the 4 pulmonary veins. And as if you see, there was electrical firing from the left upper pulmonary vein, noted here, the reversal of potentials, inducing atrial fibrillation. This is a well-known trigger and a very characteristic trigger site. We proceed with ablation around the veins. As you see in the bottom, the patient is back in normal rhythm shown here. The posterior view of the heart here showing all the ablation sites, and here's a view from inside of the heart itself. So this particular procedure called pulmonary vein isolation for atrial fibrillation in patients at early stages of atrial fibrillation in centers with extensive experience assures about 80 to 90% success that the patient can be removed from any antiarrhythmic drugs. Having said that, as Dr. Meckel showed, some of the fibrosis tissue there, the scarring tissue that we commonly see in patients, even in early stage, but most commonly in patients with more advanced forms of atrial fibrillation, it will require extensive ablation. noted here, this patient has normal heart muscle is the purple areas. Everything else is already remodeled. There are changes in there with fibrosis. And the procedure at this point, other than in addition to the pulmonary veins isolation, we perform extensive scarring ablation. And as you see in all these areas, which will assure a success rate of about 80% despite being so advanced. So there are millions of patients out there with atrial fibrillation, and there are many candidates for the procedure. Having said that, less than 10% of our patients are referred for ablation into our medical centers nationwide and actually even throughout the world. And our mission at university hospitals is to provide a better access to those eligible patients for ablation procedure. We provide our services in an integrated fashion throughout the university hospitals. With our patients with atrial fibrillation would come in to discuss initial management, we'll discuss treatment options, and among those patients that are candidates for ablation, it can be performed at the Cleveland Medical Center by myself, Dr. Merkel, and Dr. Takulev, as well as in the community hospitals at Ahuja Medical Center by Dr. Sotolongo, Dr. Sergio Tal, at Parma by Dr. Jim Ramacone, at Illyria Medical Center, Dr. Diaz, and Dr. Kwan, Kara Kwan, and at St. John's Medical Center by Dr. Masteller, Tassi, and myself to some extent. So I'll close with this, and I'll send it over to Dr. Merkel.
Thank you very much. Well, we have a few minutes left to answer your questions. And I'm going to just start off by addressing a common question that we received related to COVID-19 and atrial fibrillation. As you may be aware, patients who have COVID-19 are felt to be at a higher risk of complications if they have an associated cardiovascular condition. Atrial fibrillation is not one of the conditions that places you at higher risk of having a complication from COVID. The concern, part of the concern with atrial fibrillation is that two of the medications that were initially being used for treatment of COVID-19, which was hydroxychloroquine or azithromycin, do have the potential for serious interaction with some of the antiarrhythmic drugs that are used for atrial fibrillation, like amiodarone, dofetilide, and sotalol. So I think from a treatment standpoint, there is some conflict. However, remdesivir and plasma therapy do not affect any of the antiarrhythmic drugs that you're taking. So I hope that that clears up the COVID-19 question in atrial fibrillation. Dr. Arruda, I wonder if you could address the question about procedures. So we are hearing patients who have had their AFib ablation procedure postponed because of COVID-19 and based on the governor's order. And now they're wondering, is it safe to come in at this time? And what are we doing about their risk of COVID-19? So perhaps you could talk.
Sure, absolutely. So initially, the patients were postponed under the guidelines by University Hospital, the Heart Rhythm Society, alongside with the governor, to provide procedures only for essential cases, where patients were really symptomatic, where there's risk if not conducted at the time. So that went through the month of April. And to our knowledge, all the procedures that we have done, there was no additional exposure that we know to patients getting infected with COVID. Going forward from April 1st, we have reopened and extended procedures to patients that are non-essential in a sense in terms of levels of symptoms. We have started with a lot of caution in terms of getting patients tested prior to procedure, 72 hours prior, and wearing masks. And as far as our staff concerned, also will be protect, wearing masks, and all the appropriate protections. So yes, to answer your question, we are performing, and we feel that's safe at this point.
Thank you. We have a question from the audience, which I wanted to send to Dr. Sotolongo. I accidentally deleted it, but they're asking questions about the reversal agents that are available for the novel oral anticoagulants, and how easily available those are, and whether that's something that you take into consideration when you're prescribing these medications.
Thanks, Judy. Yeah, that's a great question. So first of all, I think one of the biggest problems when we talk about spontaneous bleeding and bleeding risk, we're really talking about bleeding in the brain. That's the biggest risk here and the biggest life-threatening risk. The new oral anticoagulant agents are at a lower risk for bleeding in the brain than warfarin, specifically because this usually occurs when our levels of warfarin are too high in the blood. Also, when the levels are too high in the blood, it is true, it takes some time for the warfarin to leave the system. So we can give vitamin K as well as fresh frozen plasma to completely reverse that. And that's one of the things that people would talk about as an advantage of warfarin over the other anticoagulants. For the time being, there are reversal agents for all new anticoagulants, novel anticoagulants at this point, and they're available in most hospitals, but we usually reserve them for major life-threatening bleeding. For the most part, for any other type of bleeding, usually you can wait it out because it doesn't take as long for this medication to clear the system as it does for the warfarin. So most of the time we try to be conservative with it, but if there is a need for major bleeding, then we can give this a reversal agent for all of them.
Thank you. Dr. Mosteller, we have a question about environmental or chemical exposures that trigger atrial fibrillation. Are you aware of any studies relating to those types of triggers?
I can't say that I am, Dr. Mackel. We will occasionally see people with lung disease from environmental exposure, pulmonary fibrosis, and people that work in foundries and have sandblasting careers and stuff, and they get lung issues that then can put a strain on the heart, cause high pressures on the right side of the heart, and lead to fibrillation. But otherwise, I'm not aware of chemical exposures that make you highly prone to atrial fibrillation.
Thank you. Dr. Arruda, we have a question from the audience. After a maze procedure that was not successful, so this was most likely a maze procedure that was done at the time of cardiac surgery, what treatment options are available for this patient?
It's important to assess the type of rhythm that's recurred after the maze. Very commonly is atypical atrial flutters. In other words, it are wave an arrhythmia that involve around the mitral valves, for instance, or other parts of the left atrium that need to be properly identified to have a target treatment. Some of our patients respond to antiarrhythmic drugs. For the ones that don't initially, they undergo a catheter ablation for those erratic flutters, typically more than one. It can be up to 5 patients, very common. We do a fair amount of these cases, or we've done this throughout the years, probably about 10 patients a year that have had previous maze that comes with very refractory flutters. So yes, I think catheter ablation is an option. I would start with an antiarrhythmic first to see the result.
Thank you. So Dr. Sotolongo, we have a question from the audience about using novel anticoagulants in the setting of underlying kidney disease. So can you speak to that?
Yeah, of course. So these medications, most of them at least clear partially through the kidneys, all of them at least partially. So they do need to be adjusted based on your kidney function. So all of these medications have a dose that's a reduced dose for patients that who have significant kidney function. So depending on the medication that you use and how bad the kidney function is, it will depend what dose you get. In patients with very severe renal dysfunction, there is some data that some of these medications are still safe. But that's still, depends on the drug and it depends on the study.
Thank you. Dr. Mosteller, we have a question about a patient with pulmonary arterial hypertension who recently on a sleep study was noted to have atrial fibrillation. They don't mention whether the sleep study showed sleep apnea, but interestingly, they note that both their father and their brother also have atrial fibrillation. And the question is, do we know if there is a genetic predisposition or if AFib can be inherited?
Yeah, that's a great question. And we haven't really sorted through the genetics of it, but it's felt that maybe all the way up to 30% of atrial fibrillation has some type of genetic basis. So I think in years to come, we will get better at identifying that and might be able to offer some novel therapies to help with that.
Thank you. And then Dr. Arruda, we'll maybe finish with you. Questions about the durability of the atrial fibrillation ablation. So deemed successful, how many years out is it good for? Do you look again? Can you have more than one ablation? What are your thoughts?
Sure. As I said there, there's more and more evidence that a fibrillation can be performed as first-line treatment for early stage of atrial fibrillation, and with the very good outcomes. Okay. Having said that, the patients that are more advanced, typically, if you do an extensive ablation, as I've shown, a recurrence rate about 20 to 30%, that with the second procedure, you were able to eliminate those residual AFibs or flutters in the vast majority of them. I don't think it's ever 100%. If you look in very serious throughout the world, that significant improvement, but some patients remain in atrial fibrillation. We will discuss some other forms of treatment with producing a heart block and pacing some of these individuals there. There is no limit number of prior ablations. We often have referrals from other states with patients having had 3 to 4 ablations and having a very refractory atrial flutter that we go in, and I don't think he increased the risk of complication of the procedure. I would say that's a fair, the way it's done today and a very extensive, even for the advanced form of patients, I think we should have a 5-year outcomes about 80% if you consider repeat ablation in some patients and additional medication.
Okay, great. Thank you all very much. I want to thank our panelists for your time in sharing this information and answering the great questions that were posed today. A couple of reminders for the audience. We will email a link to view this session on our website. To schedule an appointment with a University Hospital's heart or vascular specialist, please call 216-465-7893. This concludes today's session. Thank you for attending and have a great afternoon.